All right, let's talk about when adults move around when they sleep and some of the heart arrhythmias you will find when running sleep studies. Just to clarify, when we use the words stage and score, we mean two different things. Staging refers to sleep staging, so it's just dealing with if someone's awake in non-REM or REM. Everything else is scored, like arousals, respiratory events, movements, and cardiac events. When we're talking about limb movements in sleep, we generally mean leg movements. Arm wires aren't standard like leg wires are. So anytime a patient moves their legs while they're sleeping, we can score those. They can include both legs or just one, and it's recommended that a separate channel is used for both legs so that you have a left leg one and a right leg one. Most providers don't pay attention to individual leg movements like one every minute. They really want groups of four or more, which we would call periodic limb movements of sleep, or PLMS. To score periodic limb movements of sleep, the movements need to be between 0.5 and 2 seconds long and at least 8 microvolts in amplitude compared to the baseline. PLMS are only scored in groups of at least 4. And I'm not talking about like you have to have this group of 4 and then this group of 4. If you have a group and there's more than 4, you score all of them. The movements can have no more than 90 seconds between them and no less than 5 seconds in between each movement. As far as scoring movements during sleep goes, limb movements are usually the only movement actually scored, and you will score a ton. I've had studies that I've marked up to 500 or 600 limb movements, and that means an extra 500 or 600 clicks on the mouse. When you're staging studies, you're pressing a button for each epoch of sleep, so that's somewhere between 700 and 800 button presses. When you're scoring events, you're advancing forward through the study using arrow buttons. So that's another 300 or 400 clicks because you're usually looking at 2 minutes at a time. Lots of clicking. All the other disorders are usually just documented in the study when they happen. However, some sleep software does allow the scoring of all these different disorders, but most don't, because it's not something that you put in a report as far as what the doctor will put in there. It depends on your lab's policy and procedure and ultimately what is shown on the report. If there is not a place in the report for the number of left leg versus right leg movements, do you really need separate leg channels? Well, most reports do not report separate leg channels. However, it's good to document which limb it is especially. If the patient is experiencing pain in one leg, it might be that one that's moving a lot. Diabetic peripheral neuropathy can also cause limb movements, so if one moves more than another, that one may require further investigation. Also, if there is not a place in the report to show how much patient had hypnagogic foot tremor or bruxism or something else, then there is probably not a way to score it. Or it's not something the provider thinks needs to be listed in the report. Anything that's not listed in the report can still be added through the provider's analysis and recommendations. Here's something you don't see every night. I think this is the only study I've ever run that had periodic limb movements that weren't legs. These were arm movements. Check this out. I've got the legs right here. They're not doing anything. But I've also got arm movements, and sometimes those are used in parasomnia montages. These electrodes are situated on the forearms, and those muscles activate the fingers. So this patient is most likely flexing their fingers into a stretch or a fist. And this is a 2-minute window. You see these green lines. There's that. These are 30-second epochs, so this is 2 minutes. For PLMS, you have to have a run of at least 4 movements. Each movement has to have at least 5 seconds between them, but no more than 90. So if it has more than 3 epochs without a movement, then you can't score that one. One of the important things to remember about PLMS it's considered a problem if they cause a lot of arousals. If a patient is just moving their legs around and it doesn't wake them up, then there's no big deal. But if they arouse every 4th or 5th leg movement, that's a disorder, and it's probably depriving them of sleep. We call that periodic limb movement disorder. An interesting variant of PLMS are ALMAs, or alternating leg movement activations. I've only seen this once as a sleep technologist, and I didn't get pics of it. For limb movements to qualify as ALMAs, they must have a frequency range between half and 3 hertz, and a typical duration of 100 to 500 milliseconds. As of this presentation, there are no clinical consequences, nor has there been a specific mechanism discovered that causes ALMA, so we don't really pay attention to much of it. This is pretty fuzzy, but the important things is you can see the legs. You've got 2 electrodes on each legs, and we have alternating boom, right, left, right, left, right, left, right, left, right, left, right. This is ALMA. Here's an extended look at a study. The important things to notice are the little black blobs. One there, one there, one there, one there, one there, one there. Usually the legs are going one after another, but there is a cluster where it looks like they're going together right there. But then they go back to alternating again. Hypnagogic foot tremor means moving the feet while falling asleep. To qualify, there have to be at least 4 EMG bursts with a frequency range of 0.3 to 4 hertz. These bursts usually last between 250 and 1,000 milliseconds. There is no clinical consequences that we know of for this. So this looks a lot like ALMA. The difference is that ALMA is occurring during sleep. Hypnagogic foot tremor, hypnagogic means going to sleep. It's a little difficult to see, but you can see that there are alpha waves here. As you go forward, the leg movements stop. Kind of looks like the alpha goes away, and they get sleep right there. Then the patient appears to arouse somewhere in here. The leg movements come back. Here's some better sleep here. You get a little bit better waves. Arousal happens. They start moving their feet again. Hypnagogic foot tremor. Here's some more. Very fuzzy. But those look like little waves there. Get some good waves. And then right here, alpha. And then you have these alternating foot movements as alpha continues. Alternating is not a disqualifying factor for this movement, to qualify for this movement. As far as tremors go, these are pretty slow. Excessive fragmentary myoclonus means extra muscle twitching during sleep. EFM bursts usually last less than 150 milliseconds, and at least 5 EMG bursts per minute must be recorded to score. Also, at least 20 minutes of non-REM with EFM must be seen. Again, there is no known clinical consequence for EFM. Alright, so we've got, looks like N2 here, and you can see these little blips showing up. Mostly in the left leg. There. All these little things right there. Kind of looks like artifact. But these are little muscle cell activations. Sometimes you might hear the term spicules or fasciculations. Those just mean muscle cells are irritated and excited to the point of causing a little activation. This only occurs during sleep and does not really cause arousals. These don't count towards PLMS because they don't meet the duration requirement. Bruxism is clenching or grinding teeth. These usually occur just after an arousal. There could be brief or sustained elevations in chin EMG amplitude, also known as phasic and tonic, respectively. These instances usually last between 0.25 to 2 seconds with at least 3 EMG bursts or 3 grinds. To qualify, there must be at least 3 seconds of preceding baseline EMG prior to the EMG bursts, meaning the chin should be relatively static and not dynamic or changing before the bruxism happens. Bruxism is best seen if a masseter channel is added. The chin wires will see it, but the masseter on the side of the jaw is a giant muscle and it activates big time in the EMG. If it's audible, if you can hear them grind their teeth, you should document that you can hear it. All right, it looks like we're in non-REM here. The top two, maybe a spindle there, and then a K complex with an arousal. So we would not count that K complex towards N2. And then we have these rhythmic bursts. And you see those little tiny sharps? Those are muscle cells. And then you got a lot of them together, and they make these black blobs. Remember, muscles activate very quickly, so they will appear like waves very tightly together. These aren't brain waves, because you can see the muscle activation show up in the chin EMG down here. So why does it show up in the EEG so well? Well, if you put your hands on the side of your head so that the fingers almost meet at the top, clench your teeth, you can feel that tension go all the way up through the sides of your scalp. And that's what's happening in these electrodes. There is muscle tissue, and it's flexing. Here's a study I ran a few years ago. If you remember how to put the EOG on, one electrode goes above the eye and one goes below. Here, E1 is below the eye, and it's near the masseter muscle, and it's picking up this bruxism very well. It's pretty much doubling the chin wire there. I remember this patient. He had Down syndrome, and it sounded like he was crushing rocks in his teeth all night. That's bruxism. Rhythmic movement disorder is an umbrella term for any rhythmic movements of any type during sleep-wake transitions. Usually these are seen in children with head rocking or head banging. Head rocking is when children twist their head from side to side, and eventually this causes them to fall asleep. Head banging is when the patient picks their head off the pillow and just falls back down on it over and over and over. Sometimes these can occur in adults as well. The frequency range for these episodes are between 0.5 and 2 Hz, just like PLMS, and 4 movements are needed to score a cluster of rhythmic movements. There's no specific voltage requirement, but the minimum amplitude has to be at least 2 times greater than the EMG activity, so we want to see it pretty well. Here's an example of rhythmic movement disorder. The patient looks like they're either in N2 or N3, and then they have an arousal right there. And then we have these kind of straight line up and down looking bursts. Looks like it's happening all the way down through the study. And it looks like it was pretty quick, too. They woke up and immediately started banging their head. The technologist has entered a tech note. It's a little hard to read, but I can make out movement of head. So they were banging their head, and then all of a sudden they fall right back to sleep. Very interesting. This kind of looks like head rolling. There looks like the EEG is going down and up and down and up and down and up, and from extreme upward to extreme downward. And that would mimic the patient rolling side to side. It looks like they're also tensing the legs or rolling their whole body there. Check out those respiratory belts. It's going crazy because of all the movements. It's pretty interesting because it looks like they're asleep here. Then they immediately wake up and immediately start doing that. And then they immediately go back to sleep. And then they immediately wake up again. I mean, that's crazy. I mean, when I wake up, I have to figure things out first. You can't fake this kind of stuff, is what I'm saying, I guess. You can't fake going to sleep and then you immediately wake up and start doing something. So this is, I think, a very fascinating thing. If you haven't had the class already, you will have one that talks about reading ECGs, electrocardiographs. This should be an introduction for that if you haven't. Most likely you're not going to measure ECG waves in the sleep study. However, if you know the basics about reading ECG, you can describe what you see that may be abnormal and assist the physician in a proper diagnosis. It will also help you to know when life-threatening heart rhythms are happening. For instance, if you see a heart rhythm, that doesn't look very good, but I'm not sure if it's life-threatening or not, and I'm alone tonight. You can call the physician, and the physician, all right, what does it look like? Well, if you know what all these waves are, you could say, oh, well, the P wave, I don't see a P or a T wave. I just see these, it looks like a QRS, but it's huge. So you can say things like that, and you might not know what the rhythm is, what we might call it, but you could describe it, and that would be a lot better than nothing. So first, we need to basically know how to read the time on ECG paper. Every ECG machine is calibrated so that 1 millimeter is one box, and every millimeter of paper that passes is 0.04 seconds, or 4 milliseconds. We have groups of those boxes in fives, and that translate horizontally, going left to right, into 5 millimeters. This is time from left to right. 5 millimeters equals 0.2 seconds, or 200 milliseconds, because 5 times 4 is 20. These groups are further grouped into another 5 boxes, so that whole thing could fit into here. So this would be 25 millimeters, or 1 second. The vertical boxes represent voltage, just like EEG, but we don't focus on that. That's getting into advanced ECG stuff. We're more focused on the duration and the morphology, or what every wave looks like. All right, the first wave of a heartbeat is the P wave. It's just a little upward and downward bump. That should last approximately 80 milliseconds. After the P wave, there's a period where nothing happens, and we call this the PR segment, or the PR, yes, this is the PR segment, because it is going from the beginning of the P wave to the beginning of the R complex, the QRS complex. The interval means a space between two waves, and that PR interval is about 120 to 200 seconds. After the PR interval, we have the classic 3 waves that makes a heartbeat looks like a heartbeat. The first one goes down, that's the Q wave. Then we have the R wave. That's a big upwards deflection. And then another big sharp deflection down. That's the S wave. Together we call these waves the QRS complex. And that lasts sometime between 80 and 100 milliseconds. After the S wave deflects downward, there's no real activity. So this isn't another wave, it's just a repolarization to 0.0 baseline. After that happens, we have a little bit of time, and this is actually when the heart is repolarizing. Then we have this one right here, that's the T wave. And a lot of times it's bigger than the P wave. The T wave generally lasts about 160 milliseconds. The time between the S repolarization and the T wave is called the ST segment. If you know what normal sinus rhythm looks like, and you can describe, this is what normal sinus rhythm looks like, you can describe the P wave, the QRS wave, and the T wave, you can already determine a lot of irregular heart rhythms comparing it to this. Here's what a typical ECG beat would look like on paper. Conveniently, the wave starts right on a box, so we don't have to start counting in the middle of boxes. Check out the box layout. We have tiny boxes, which are 40 milliseconds, grouped into 5 tiny boxes, representing 200 milliseconds, and then we're looking at 5 big horizontal boxes from left to right, which represents a second. Here's normal sinus rhythm. We have a clear P wave, which starts the beat, a QRS, which isn't too thin and isn't too wide, and then a bigger bump at the end, which is the T wave. Really focus on how these features look like and how they change in the next few slides. Here are the scoreable cardiac events. Again, it's usually up to the sleep software and the provider and the report generator whether cardiac events are scored. The AASM says arrhythmias are scoreable. Also, remember, these are also while we're asleep. Bradycardia and tachycardia have different values for wake and sleep and for adults versus kids. Sinus tachycardia is just a fast heart rate, higher than 90 beats per minute. Sinus means it's still a normal heartbeat as far as the sinoatrial node is pacing the beat. Asystole, or a cardiac pause, is when there is no electrical signal coming from the heart for at least 3 seconds. Bradycardia is a heart rate less than 40 beats per minute for patients ages 6 and older. I've seen this a lot with really tall men or very athletic people. Wide complex tachycardia is a fast heart rate, more than 100 beats per second, and the QRS complex lasts longer than 120 milliseconds. There have to be at least 3 beats of at least 100 beats per minute for it to be wide complex tachycardia. Narrow complex tachycardia looks more like a normal fast heart rate. The QRS complex is less than 120 milliseconds. Atrial fibrillation is when the upper chambers of the heart, the atria, are just kind of shaking instead of pumping. This makes the QRS complexes occur at different times because the SA node is not triggering that cascade of current that makes the heart beat as an integrated unit from top to bottom. Instead of P and T waves, you'll just see a wiggly line. Similar to fibrillation is flutter, and those appear like a jagged point instead of like a wiggly line, similar to sawtooths. Ectopic beats refers to heartbeats that emanate or originate from any other heart cell other than the SA node, which is the natural pacemaker. These could be premature ventricular contractions, or PVCs, premature atrial contractions, or PACs, and heart blocks. There are 2 kinds of heart blocks. We have electrical heart blocks, which is what we're talking about here, and physical heart blocks, where it's not really the heart being blocked, but a blood vessel is being blocked. Here's sinus tachycardia. The nice thing about modern sleep software is that it will have a running pulse channel to tell you how fast the heart rate is, so you don't have to do it. There's a P wave, a QRS complex, and a T wave. You might notice this is a fast heartbeat because it looks pretty normal, but nevertheless, look at the distance between the T wave and the P wave. There's not very much light there. And so that's one way you can tell if it's a faster heart rate. Bradycardia is the opposite of tachycardia, too slow. Instead of a very short interval between the T and the P wave, well, it's quite a very big interval. Like I think that last one was maybe half a box. This is almost 3 boxes. It is 3 boxes. The longer the interval, the slower the rhythm. For sleep, we're looking for 40 beats per minute or less as bradycardia. Here's a cardiac pause. First, we have a normal P wave, a QRS complex, and T wave, but then nothing. There is absolutely no electrical signal there at all, and it lasts just about 3 seconds. After 3 seconds, it comes right back into normal sinus rhythm. Scary stuff, I think. Fun fact, asystole is an unshockable rhythm. Medications are the only thing that can try and get the heartbeat to come back. Here's wide complex tachycardia. You don't see anything but this just thing here. And what this is these are wide and bizarre, and these are QRS complexes. You can't see any P waves or T waves at all. Unless there's a note in the patient's chart that this is a normal rhythm for them, I would really consider getting help with this beat. Here is narrow complex tachycardia, and you can't see it very well, but the QRS has very little space in between it, and it's less than 120 milliseconds, so that's very thin. That means the the electrical contractions might be happening too fast to get the blood all the way out of the ventricles. Remember, fibrillate is to jiggle or shake, like Santa Claus. In the top, you can see there aren't really any good firm P waves. That might be one. I don't really see anything there. That's very strange. There's not just like a P and then a T. That looks like a T and then maybe a P and then nothing else is. Jiggle, jiggle. There's really nothing there. T wave. Oh, there's not much. And check out the QRS complexes. One happens here, here. That looks about the same length. This one's quicker. This one's a bit longer, then shorter, then a little longer, about the same. The QRS beats, they're not happening at the regular intervals. Here we have flutter. That's a very typical sawtooth wave, and every once in a while you get a QRS complex. Flutter, that jagged edge obscures the P and T waves, so you can't really tell which it is. For flutter, it's usually got 3 to 4 little jagged edges in it before a QRS complex. Here are some PVCs, premature ventricular contractions. These are from 2 different ventricular locations because we see 2 different forms. Here's one. Here's one. They both look totally different from the beats. These are not PACs. Those usually just look like regular heartbeats. A couplet is when 2 PVCs occur, one right after the other. There it is right there. 1 PVC, 2 PVC. There are also triplets, which are 3 beats in a row. I don't have any slides of those, but there are also bigeminy, which is a normal beat followed by a PVC, then a normal beat, and then a PVC, that kind of rhythm. Also, there's trigeminy, which are 2 normal beats, then a PVC, 2 normal beats, then a PVC. If not scored, these different heartbeats should be documented as they occur in the study. And this is ventricular tachycardia, a potentially life-threatening heart rhythm. This is one that I ran. And the only reason I didn't activate the emergency service was because the patient continued to have good readings on the pulse oximetry down here. And I went and checked the peripheral a pulse, and it was strong. If the patient is not responsive, you can't palpate a pulse, or the pulse oximeter is no longer giving you a signal, that's a good idea to try and wake up the patient. You better believe I almost pooped myself when this happened, man. It was some of the longest minutes I've ever had as a sleep tech. The guy ended up being fine for the night, but I was glued to that monitor. There are other arrhythmias, but this covers what you'll mainly see. But this is ventricular tachycardia. If you see this, you better pay attention. All right, so if you know the basics, you'll be fine. This isn't going to be the last time you hear about the heart if you're already talking about it now. There's going to be a course that goes over this quite a bit more. So do your best. The heart can be kind of tough, but if you work at it like I've worked at it before, it'll come to you.